Hello and welcome. In this session, we're doing a clinical update on Impetigo, and we're going to cover a really crucial new management guideline that's going to directly impact your daily practice. Now, all of this is based on the excellent work of Dr. Mohammed Al-Nagi Mohammed. So let's get started.
So here's our game plan. We'll kick things off with a quick clinical overview, then get into how it's transmitted and what it looks like. After that, we'll dive into the really pivotal updates for managing both localized and extensive disease, and we'll wrap up with some essential public health guidance that you can pass on to your patients.
All right, Section 1, the clinical overview. Let's make sure we're all on the same page with the fundamentals of Impetigo. The key word here, the one I really want you to lock onto, is superficial. Impetigo hangs out in the outermost layers of the epidermis, and that location is so important because it explains pretty much everything, from its classic look to the fact that it usually heals up without any scarring. So, who are the main culprits? Well, it's usually our old friends Staphylococcus aureus and Streptococcus pyogenes. And clinically, you gotta distinguish between two different scenarios. You've got your primary impetigo, which just shows up on otherwise healthy skin, but then you have secondary impetigo. You can also call it impetiginization, which is more of an opportunistic infection that jumps on a pre-existing problem, like a patch of eczema, scabies, or even just a simple insect bite. Demographically, you are going to see this most often in kids. And the link to warm weather, that just makes sense, right? Kids are outside more, getting more of those minor cuts and scrapes, and the weather is just perfect for bacterial growth.
Okay, moving on to Section 2. Now that we know what it is, let's talk about how it gets around and what you should be looking for in the clinic.
Understanding this chain of infection is just so key for patient education. It all starts with direct contact. Then the bacteria find a way in, usually through a tiny little break in the skin you might not even see. And number 3 here is a perfect illustration of auto-inoculation. A child scratches one spot, then touches their face, and boom, they've spread it themselves. And we can't forget about fomites. Things like shared towels or toys can easily pass it along indirectly. Here's a time frame you'll want to remember: 4 to 10 days. This becomes really clinically relevant when you're taking a history, trying to figure out the source of an outbreak in a family or a nursery setting. When it comes to diagnoses, this slide is pure gold. That classic golden or honey-colored crust is the pathognomonic sign. It's a look you won't forget. Remember, these lesions are incredibly contagious, and you'll usually find them on exposed skin, the face, especially around the nose and mouth, and on the arms and legs. All right, Section 3. We've now arrived at the absolute core of this update. This is about a major, guideline-driven shift in how we handle localized disease. This is important. So take a second and think about this. A child comes in with just a few crusted lesions on their chin. They're otherwise well, no fever. What's your go-to prescription? What are you writing down first?
And here is the new answer. The 2020 guideline from NICE and Public Health England now recommends hydrogen peroxide 1% cream. This is a huge move away from just automatically reaching for a topical antibiotic in these simple, localized cases.
So the big question is why? Why this change? Well, it's a direct shot at the growing threat of antimicrobial resistance. The evidence shows that for your standard non-bullous impetigo, hydrogen peroxide works just as well as a topical antibiotic, but without fueling resistance. This is what antibiotic stewardship looks like in practice. This table really lays out the new treatment algorithm perfectly. Hydrogen peroxide 1% is your new first-line choice. Topical fusidic acid, which used to be the star player, is now second line. And topical mupirocin? That needs to be reserved for very specific situations, like if you're suspecting fusidic acid resistance or you're dealing with confirmed MRSA. Okay, Section 4. Of course, not every case is a simple, localized one. So let's talk about what to do for those more extensive or severe presentations. Right, so when the disease is widespread, or maybe the patient is starting to feel systemically unwell, we have to step up to systemic therapy. First-line choice here is oral flucloxacillin. It's a great choice for targeting Staph aureus. And if you have a patient with a penicillin allergy, the standard alternative is still oral erythromycin. And finally, Section 5, public health guidance. Because let's be honest, our job isn't done until we've educated the patient and their family on how to stop this from spreading. This is probably the single most common question you're going to get from parents, and having a clear, confident answer is absolutely crucial. The time-based rule is nice and simple. If they're on antibiotics, they need to stay home for 48 hours after that first dose. It's a clear, easy rule for parents to follow. But, and this is an important but, There is another option. A child can also go back once all the lesions are completely crusted over and healed up. This is especially relevant if they were treated with just hydrogen peroxide or if they just healed really, really quickly. So if there's one thing to take away from all this, it's that shift, that move towards a non-antibiotic first-line treatment for localized impetigo. It's a direct strategy to fight back against antimicrobial resistance. And it leaves us with a pretty critical question to think about. As this challenge gets bigger, how will our approach to other common infections have to evolve too? Thanks for joining me for this explainer.